Well, good morning or good afternoon, depending on where you are. My name is Joy Burkhardt, and we're so pleased to have you join us today for our first webinar in a webinar series addressing workforce this summer. This title webinar is Understanding the Role Nurse Practitioners Can Play in Maternal Mental Health. We're so grateful to the two speakers that are joining us today, and I'll introduce them in just a moment. We can move to the next slide. And as we are moving to the next slide, I want to take a moment to invite all of you to drop into chat which one of these Ps you represent. So we know that you're joining us today because you are a change agent in maternal mental health in some fashion. Are you with a provider health system? Are you a policymaker, either at an agency or perhaps even a legislative role? Are you a payer? Are you an insurer with a Medicaid agency, perhaps an employer? Or are you a partner, a national nonprofit organization, a community-based organization, or perhaps a philanthropic partner? We'd love to hear from you in chat. If you can drop in where you're from, that's great. Thanks, Morgan. And if you want to drop in the organization you're with as you list your P, you're welcome to do that as well. But it looks like we have some national nonprofit partners I see, some providers. There we go, provider, Morgan, thank you. It's helpful to know where you're all coming from and your interests today. So thank you. We invite you to continue to drop in which P you are and the name of your organization if you wish. Well, welcome again. And again, my name is Joy Burkhardt, and I'm the Executive Director of the Policy Center for Maternal Mental Health. And our mission is to close gaps in maternal mental health care, and addressing access to care is a primary focus area of ours. We move on to the next slide. Today, I'm really pleased to introduce our two speakers, starting with Sue Kindig. And I need just a moment. There we go. I moved something. Sue Kindig is a board-certified women's health nurse practitioner and an attorney with 4 decades of experience as a clinician, educator, and strategist. Her work is grounded at the intersection of clinical practice, policy, and public health. She's a practicing nurse practitioner with SSM Health Maternal Services in St. Louis, Missouri, serves as the director of WHNP Practice and Policy. She'll tell us more about Women's Health Nurse Practitioner Organization in just a bit. That organization is the National Association of Nurse Practitioners in Women's Health. And she's an adjunct professor at the St. Louis University School of Public Health and Social Justice, Center of Excellence in Maternal and Child Health Education and Sciences and Practice. She's committed to facilitating the intersection of women's health and mental health services. She's worked to develop primary care and behavioral health home and other value-based initiatives. She has significant experience in working in maternal health safety, including serving as a co-lead in developing the Alliance for Innovation and Maternal Health bundles related to maternal mental health, postpartum care, and women's health care in general. She is clearly a leader in our field. We're so thrilled that she's with us. And Sue, thank you very much. Next, I'd also like to introduce Teresa Nguyen, our next speaker. She's been practicing as a board-certified psychiatric mental health nurse practitioner with a focus in reproductive psychiatry since 2007. She holds a PhD in nursing as well. Teresa has had the privilege of working across various clinical settings, including the outpatient setting at New York Presbyterian Weill Cornell Payne Whitney Clinic's Women's Health Reproductive Psychiatry program, and the intensive outpatient program at UC San Diego, Women's Reproductive Mental Health program, and in private practice. And she's currently working for a county mental health department. Specifically, she sees patients 1 day a week at the Los Angeles County Department of Mental Health, which is one of the largest mental health service systems in the country. She is also a in her postdoctoral fellowship through the National Clinician Scholars Program at UCLA. Her research interests are centered at the intersection of Asian American women's reproductive mental health. We are so thrilled to have both of you join us today, and we can go ahead and advance to the next slide, and I'm going to turn it over to Sue. Sue.
Thanks so much, Joy. Can we go ahead to the next slide? Hi, everybody. I'm so pleased to be here today. And my job is going to be talking about how nurse practitioners really fit into the picture in terms of providing screening, diagnosis, and treatment for reproductive capable people who may be experiencing mental health issues. And so we're going to talk about the different types of nurse practitioners and how they intersect with maternal mental health, because one of the takeaways for today is a nurse practitioner is not a nurse practitioner is not a nurse practitioner. We all are educated, excuse me, in a population foci, and that has some implications for how we intersect with maternal care. But the most important thing is to remember that we all do have that intersection in touching maternal health care in some way. I'm specifically then going to describe the role of women's health nurse practitioners. And my colleague Teresa will be talking specifically about psych mental health nurse practitioners. Goodness, excuse me. Next slide, please. So why this focus on nurse practitioners today? Well, we know that maternal mental health is a significant issue. In fact, if we look at the statistics from maternal mortality review committees across the country, um, mental health conditions are one of the leading causes of maternal mortality. And this risk extends not only throughout the prenatal period, but throughout the first year postpartum. So as I'm talking about how we are all providing care for pregnant and postpartum people during this time frame, I want us to remember that we're talking about probably a 2-year time span where we really need to be thinking about pregnancy and postpartum related mental health conditions. And I would also invite us to consider that early recognition of mental health risk and treatment before pregnancy and between pregnancy is also going to be really important. So the bottom line is we need all hands on deck to assure that we are identifying mental health conditions early and that people have access to the appropriate treatments and supports so that they can be as well as possible and their health outcomes optimized. Next slide, please. Okay, so nurse practitioners are definitely part of the solution. And I hear from my colleagues many times we are silent providers in this discussion because oftentimes when we think about maternal health care, our mind tends to go to our physician colleagues and our midwifery colleagues, and yet nurse practitioners make up a significant part of the workforce addressing maternal health issues, including maternal mental health. And if we are excluded from policies, from regulatory language, from utilizing our skills in clinics, hospitals, et cetera, we are really not fully leveraging the entire workforce that can be available. So what are nurse practitioners? Well, nurse practitioners are advanced practice registered nurses, and we are prepared through academic and clinical study beyond our basic nursing education for practice as a primary and or acute care nurse practitioner. Generally, that education is at the graduate level, either a master's or a doctoral degree. In addition to that, we hold certification specific to our population foci by a nationally recognized credentialing body. And that will be in alignment with what our population foci or specialty would be. We are recognized as both primary and acute care providers, and we are also qualified to practice in specialty and subspecialty areas that are consistent with our education and experience. And I'll talk about that as I go along. Next slide. Now, there is a regulatory model that really guides APRN practice. And when I talk about the population foci, what that means is that we are educated, credentialed, or certified to practice within one of 6 population foci. So family, adult gerontology, neonatal pediatrics, women's health and gender related, and psychiatric mental health. Each of those population foci have their own educational curriculum requirements. Our certification is specific to that population foci, and it builds on our experience as a nurse practitioner. Now, I mentioned before that nurse practitioners are advanced practice registered nurses. There are 4 different types of APRN roles: nurse anesthetists, nurse midwives, clinical nurse specialists, and nurse practitioners. So when we think about this from a regulatory scheme in many states, APRNs are treated similarly in terms of whether or not we can practice independently, or if there is a need for a collaborating physician colleague. But all of these roles will have, again, distinct educational requirements and certification requirements. Next slide, please. Okay, so let me explain just a little bit about the different types of nurse practitioners, because we've already established they're advanced practice registered nurses. A nurse practitioner is one of the APRN roles. And now we're going to talk about the different population foci. So I think the easiest way to think about it is if we think about our physician colleagues, we know we have obstetricians, we have internal medicine physicians, family practice, etc. That kind of helps to frame what these population foci mean. So adult gerontology nurse practitioners pretty much care for adolescents, young, middle adults, and so forth. Now, where does that intersect with maternal mental health? Well, they may well be seeing people during that first year postpartum as they transition to well woman care. So they may be doing those mental health screenings and perhaps initiating treatment at that point in time, certainly caring for chronic disease. So as people are transitioning from prenatal and postpartum care to their well woman care and their chronic disease, they may be seeing adult gerontology nurse practitioners, very similar to internal medicine. Family nurse practitioners provide primary care across the lifespan. In terms of providing primary care across the lifespan, that does include providing prenatal and postpartum care. There are probably more, well, there are more family nurse practitioners than any other type of nurse practitioners. About 70% of nurse practitioners are family nurse practitioners. That does not necessarily mean they all are providing obstetric care, because they may work in family practices that don't provide obstetric care and so forth, but they are still touching people during this prenatal and postpartum time, because again, as people transition from their pregnancy and early postpartum care to primary care, they may well be seeing a family nurse practitioner colleague. Neonatal nurse practitioners are providing care to those preterm and term neonates, as well as children up to 2 years old that require complex care. We know that people who give birth to a preterm or a neonate that has health conditions are more likely to experience mental health conditions. They may be the first line of defense. They may be the ones who are actually recognizing that there's a problem and need to initiate the referrals. Our pediatric nurse practitioner colleagues caring for children from birth through young adulthood, sometimes 18, sometimes 21. So they're seeing people in that pre-pregnancy state, making sure that they're healthy. They may well be seeing someone back in their practice who's postpartum if we've had an adolescent pregnancy. Psychiatric mental health nurse practitioners, Teresa is going to tell you all about them. And certainly there is an intersection throughout the reproductive lifespan with our psychiatric mental health nurse practitioner colleagues. And then women's health nurse practitioners care for women across the lifespan from puberty on. So, and that when I say women, that is really inclusive of all gender identities. And there's an emphasis on reproductive and gynecologic care, obstetric care, um, reproductive health, et cetera. And we also provide reproductive and sexual health care for men. And importantly, of these 6 population foci, women's health nurse practitioners are the only ones with enumerated competencies in providing care for high-risk pregnant and postpartum people. And again, we know that people who are experience a high-risk pregnancy are again at greater risk for having mental health conditions. Next slide, please. Now, let's go back and talk about nurse practitioners as a whole. Again, we practice independently and collaboratively to provide evidence-based assessment, diagnosis, treatment, and management. So, irregardless of which population foci you are in, and one of the things I'll mention is I taught nurse practitioners for 20 years. I coordinated a women's health nurse practitioner program for over 20 years, but also taught across those population foci with things like pharmacology, physical assessment, and so forth. So we are prepared educationally and through our certification to assess, diagnose, and treat and manage issues, including mental health conditions. Now, certainly, people who are psychiatric mental health nurse practitioners are going to be the ones that we are going to be sending complex patients to and so forth. But nurse practitioners are educated to do screening, provide care for people who may have mild to moderate psychiatric problems, coordinate those referrals, and perhaps co-manage with our psychiatric colleagues depending on what that patient needs. NPs will work in a variety of settings. I know many times people think we're only in clinics or outpatient settings. That isn't necessarily true. You'll find us certainly in those outpatient settings, but particularly in maternal health. Many times you will see a nurse practitioner, particularly women's health nurse practitioners, working on those high risk antepartum and postpartum units, which again provides additional opportunities to screen for mental health issues, initiate treatment, and certainly those important referrals. As licensed healthcare providers, we are subject to the scope of practice rules and regulations pursuant to the the Nurse Practice Acts in our respective states. And again, usually those regulations will determine whether we need, again, a collaborative practice agreement or some type of supervisory agreement with a physician colleague, or if we are practicing independently, that may influence what we need to do to be able to provide controlled substances, those sorts of things. So it's important when working with nurse practitioners, or actually with any advanced practice registered nurse, not only nurse practitioners, to know what those state regulations are. Next slide, please. But I just want to underscore how important nurse practitioners are to providing care to people throughout that reproductive continuum, including pregnancy and postpartum. Again, because we need all hands on deck to screen for and certainly initiate treatment and help to facilitate people getting into the appropriate mental health care and supports. Again, graduate from nationally accredited programs, and are prepared to provide cost-effective care to geographically diverse populations. In fact, about 1/5 of all primary care services in the US are provided by nurse practitioners. And there was a study done by the Office of the Inspector General, gosh, back in the 80s, that found that advanced practice nurses and advanced practice professionals could actually perform about 85% of primary care healthcare. I'm sorry, about 90% of primary care healthcare and about 80% of specialty. So advanced practice professionals are really key to providing care in both the primary care as well as the acute care and specialty workforce. Um, about over 2/3 of nurse practitioners have been prepared to provide care in primary care. And when I say that, generally prenatal care, particularly uncomplicated prenatal care, is considered primary care. Next slide, please. So we're also seeing nurse practitioner supply increasing more than our physician colleagues' supply, and the highest NP supply seems to be increasing in our rural areas. So when we think about not only maternity deserts, but psychiatric care deserts and primary care deserts, nurse practitioners are being prepared to fill that need. And when there have been evaluations of NP management with our rural and uninsured populations with chronic diseases, there has been shown significant improvement in health outcomes as well as decreased emergency room, inpatients admissions, and other healthcare costs. So again, lots of information around the effectiveness of this type of care. We're also more likely to be located or practicing in areas where there may be lower socioeconomic or health status or higher need. Next slide, please. So all of that being said, I'm going to talk specifically about women's health nurse practitioners because um, of the 6 nurse practitioner population foci, women's health nurse practitioners tend to align more closely with that obstetric care component. About over 80% of women's health nurse practitioners are practicing in some type of generalist obstetric gynecology practice, whether it's been in an OBGYN office or a clinic, and so forth. And then about 16% are in specialty and subspecialty practices. So what do? We provide that primary care from puberty through the adult lifespan, focusing on both common and complex gynecologic, sexual, and reproductive health issues. Providing, again, we are the only of the 6 population foci that have enumerated competencies in uncomplicated and high-risk antepartum and postpartum care, as well as sexual and reproductive health care for men. The care is inclusive of all gender identities. And one of the things that is important is that we do not have a primary care or an acute care designation. The only population foci right now that have either of that designation are either our pediatric nurse practitioner colleagues, as you saw on the chart earlier, or our adult gerontology nurse practitioner colleagues. Women's health nurse practitioners can provide both primary and acute care. So you may see us again, as I mentioned before, on some of those high-risk units, perhaps in antepartum triage areas where people are coming in to see, if they're in labor, to be evaluated for issues like preeclampsia and so forth, as well as in general outpatient settings. Next slide, please. What do? We have an extensive set of competencies. The National Association of Nurse Practitioners in Women's Health, which is the organization, the professional organization that gives voice to the certified nurse practitioners, the certified women's health nurse practitioners in the United States, holds those competencies, which provide the foundation for both our education, our certification exams, as well as our practice. And we have core competencies in providing primary care. As I mentioned earlier, we provide primary care for women across the lifespan from puberty and beyond. Women's gynecologic, sexual, reproductive, menopause, and postmenopause health, male sexual and reproductive health, as well as obstetric care. And if you were dying to learn more about us, you can go to the NPWH website And you can download your own copy of this document. It's about 40 pages or so that'll tell you, um, sort of give you broad brushstrokes of what we do. Next slide, please. Okay, now, where do women's health nurse practitioners practice? There are over 385,000 nurse practitioners in the US, certified nurse practitioners. And of those, only about 13,000 are women's health nurse practitioners. So only about 2.2% of all NPs are women's health. As I mentioned earlier, about 70% are family nurse practitioners. Now, they practice, NPWH surveyed women's health nurse practitioners. Gosh, it's been about 5 years ago now, so we're due to do another survey. But you can see here where we are seeing them practice. Now, about 16% of the respondents reported caring for hospitalized patients, with the majority, and high-risk patients, with the majority providing antepartum, postpartum, or gynecologic care, as well as pregnancy-specific care that included antepartum testing and antepartum triage. Um, you'll also find them in hospital settings, or working with complex cases, such as gynecologic oncology, breast conditions in oncology, and urogynecology, which are some of the subspecialties that you'll see women's health nurse practitioners working in. We're prepared to do that because of our foundational educational training, that provides the foundation for then going into some of that specialization. We also will be working in reproductive endocrinology or infertility practices. And again, mental health assessment is part of all of that care. Next slide, please. So what this slide is just giving you some of the highlights from the document that I showed you, the guidelines for WHNP education and practice, and some of the core competencies that are pulled out in there that really point to that education and assessment for psychological, behavioral health, substance use disorder, and so forth, um, assessment, diagnosis, and treatment. And there is extensive curriculum that looks at both pre-pregnancy, prenatal, and postpartum physical and mental health conditions, complications of high-risk pregnancies, as well as pharmacology in terms of what is safe to prescribe during pregnancy, what's the interaction during pregnancy, and so forth. We also do a fair amount of work with substance use disorders in pregnancy, and are qualified to become certified for medication assisted treatment therapies for opioid use in pregnancy and postpartum. In fact, the health system that I work with in the St. Louis area has one of the largest perinatal substance use disorder treatments programs in the bi-state region here, and many of the core providers are women's health nurse practitioners. Next slide. In addition to all of that, there are client-centered competencies that further support addressing mental health issues during pregnancy and beyond. Next slide, please. Now, we hear so much about maternity deserts and shortage of women's healthcare providers. And I just want to point out that while there are fewer of women's health nurse practitioners than our other nurse practitioner colleagues, we still are part of the solution to providing women's health care across the country. It's expected that the overall demand for obstetric care providers is expected to increase by 4% by 2030. This is from a 2021 HRSA workforce projections document. However, the number of OBGYNs is expected to decrease by 7%, while they are projecting that our certified nurse midwifery supply is expected to grow by 32%, and women's health NP supply is supposed to grow by 89%. I will say I question that number, because when you think about people retiring, I know many of NPWH's members um, are sort of midlife and beyond. So having people coming into that workforce, I'm not so sure we are going to see that projected growth. Our numbers in terms of certified women's health nurse practitioners has remained kind of static. Um, but I also want to point out that, and this map only reflects the number of certified women's health nurse practitioners in each state, because we can get those numbers. We know that again, over 80% of women's health nurse practitioners are in those generalist practices providing obstetric care. And of those who are specializing, most of those are in maternal and fetal medicine practices. So they're touching obstetric patients. Um, with with our FNP colleagues and the other nurse practitioner population foci, they may or may not be. So it's really hard to get how many people are actually doing obstetric care. But this gives you an idea of, where we need to have where our workforce is and where we need to grow that workforce, because while we're worrying about the OBGYN shortage, there are only about 14,000 certified nurse midwives in the country, and there are only about 13,000 of women's health nurse practitioners in the country. So we really need to be looking at growing our women's health workforce in general, so that we have people who are prepared to work with reproductive capable people and including their mental health conditions. Next slide. I think we're going to save questions for later, or you can put them in the chat and I'll be watching that while I turn this over to Teresa.
I also just wanted to say thank you so much, Sue, for the overview of the various forms of nurse practitioners and going in depth on women's health nurse practitioners. Thank you, Sue. And we will turn it over to Teresa to tell us more about psychiatric nurse practitioners. Thank you, Teresa.
Wonderful. Thank you. We can jump to the next slide. So psych mental health nurse practitioners are a significant part of the US psychiatric workforce, making up more than a quarter of the total workforce. Rounding out, we have 1.7% of the workforce represented by our physician associate colleagues, and then 1.3% of the workforce represented by our psychiatric pharmacist colleagues. Next slide, please. Some quick stats about psych mental health nurse practitioners. There are, as of 2022, there are just over 22,000 of us. We are a growing workforce, in fact, nearly doubling in our numbers in the past decade. But as you can see by the median age of our workforce, we are facing a large number of us retiring. You can also see that there's a need for a more racially diverse workforce. Where are we working? What kind of settings are we working in? 70% of us are working in the outpatient setting, with a large amount of us working in federally qualified health centers, mental health, community mental health clinics, the VA, and then in terms of when we're thinking about the inpatient setting, a large number of us are working in state psychiatric hospitals. We're also working in substance use treatment centers and then integrated care settings as well. As part of the response to the opioid epidemic, as of 2010, all trainees in psych mental health nurse practitioner programs receive some kind of medication-assisted treatment training. A large number of psych mental health nurse practitioners are using telehealth, and we're licensed to use telehealth across at least 2 states. So having far-reaching effects of the people that we're able to serve. Most of us are, more than 40% of us are treating mostly Medicare and Medicaid clients as well. Next slide, please. In terms of geographic distribution across the country, this is a map of the US advanced practice psychiatric nurses per 100,000 population. As you can see with the states that are denoted in the darker blue color, we're concentrated primarily in the Northeast and the Pacific Northwest. We're at least concentrated in California, Nevada, Oklahoma, West Virginia, and Illinois. Next slide, please. We provide a myriad of behavioral health services. This is a survey that the American Psychiatric Nurses Association did, looking at how we're spending our time in terms of what kinds of services were provided. And it's listed here in descending order of what services the respondents in the survey said they spent their time providing. So mostly in most settings, we are used as prescribers and diagnostic evaluators. However, we also provide psychotherapeutic interventions at the individual, group, couples, and family therapy levels, as well as case management, crisis intervention, consult liaison services, and then also working in substance use. Next slide, please. In terms of when we drill down specifically into psych mental health nurse practitioners and maternal mental health, there's more research that we need to do to better understand how much reproductive psychiatry and maternal mental health content is offered across our curriculums. And we also need to understand that there are postgraduate residencies and fellowship that psych mental health nurse practitioners can participate in so that they can specialize in reproductive psychiatry and maternal mental health. Just doing a brief internet search, there are two systems that are offering these fellowships and residencies. One is the University Hospitals of Cleveland Medical Center, and then also a program at the VA in Bedford, Massachusetts, that's offering and including psych mental health nurse practitioners in reproductive psychiatry fellowships. We also need to better understand how many of us nurse practitioners are getting certified in perinatal mental health through organizations like Postpartum Support International, as well as other certifications and continuing education units that are available in maternal mental health. Next slide, please. So the key takeaways really are that we're a significant portion of a psychiatric workforce. We need a more diverse workforce. We work across various settings and touch a lot of people in different levels of care. We're concentrated in the Northeast and Pacific Northwest, and we need more data about us nurse practitioners that specialize in maternal mental health.
Great. Thank you, Teresa, for that overview. I know my wheels are turning. I suspect folks joining us today also have some questions. And so we are going to open the floor for questions, specifically inviting you to use the Q&A feature of Zoom to drop your questions into the Q&A feature, and we will start to go through those. I'm going to kick us off while we're waiting for questions. And I would like to ask, Sue, you the first question around the HRSA, and folks, so you remember what HRSA is, the Health Resources Services Administration in the federal government. Those workforce predictions for the future, it was pretty stark that there was such good news, it seems, around the number of women's health nurse practitioners that are projected. And I'm wondering if you can tell us why they are projecting so many new nurse practitioners in the workforce. Is it because there are federal dollars associated with training? I know we have at least one colleague also from UNC Chapel Hill who is in a nurse practitioner program receiving federal funding to train more nurse practitioners, not specifically women's health nurse practitioners, but just curious if you can give us a lay of the land around those projections, and does it have something to do with federal funding?
I'll be honest, Joy, I really don't know. It's the modeling that they used that made the predictions. And it, as I said during the presentation, it doesn't seem to line up with with what we tend to be seeing programmatically. It would be good news if we did see that. Um, but, some of the things that I think we need to think about from the funding perspective. Yes, there are federal dollars. However, um, there are federal dollars to address healthcare providers in maternity deserts, if you will. Interestingly, according to that HRSA program and their accompanying regulations, women's health nurse practitioners are not eligible for that funding. That funding is only available for OBGYNs, family practice physicians, and certified and nurse midwives. And when we have had women's health nurse practitioners, and that by definition is in the regulation. So when women's health nurse practitioners have attempted to apply for that funding, they have been denied. And I think that speaks to what I said earlier, in that we are a hidden part of the maternal child workforce, because unfortunately, much of what we focus on when we talk about maternity deserts is the 12 hours of the birth.
Mhm.
And that is an extremely important part. I mean, I do a lot of work in rural Missouri, and I have seen firsthand the risk that um, accompanies having to drive 2 hours to get to a delivery site. So I don't want to minimize that, but there is a lot of care that happens prenatally, postpartum, partally, before and between pregnancies, where there aren't a whole lot of providers in those deserts providing that care either. So we really need to look at how we're defining that. Now, there is federal funding to support nurse practitioners in primary care. So women's health nurse practitioners can access the HRSA funding for for general primary care. However, not necessarily that maternity funding.
Really helpful, Sue. I know my head goes to a federal bill that's pending, that's called Midwives for Moms, and whether there's
Mhm.
an opportunity to modify language there to be inclusive of nurse practitioners and women's health as well. Thank you, Sue, for that. I'm going to turn to both of you now. Teresa, the slide that you shared, where you described the states where there's a plethora is probably a wrong word, relatively speaking, to compared to other states, many more psychiatric nurse practitioners. I was wondering if you could explain why that is, and then Sue, I imagine there might be similar disparities with women's health nurse practitioners. So would like to start with you, Teresa, and then we'll turn it over to you as well, Sue.
I'm not exactly sure why it's so disparate, but I would imagine that part of that has to do with the scope of practice regulations within that state that can be a burden for nurse practitioner practice in terms of administrative time and also cost. So thinking about psych mental health nurse practitioners that have to pay, one study that was done by Chapman and colleagues at UCSF showed that some nurse practitioners are paying between $1,500 and $3,000 per month for supervision from a psychiatrist. And so certainly that can be prohibitive to practice.
Yeah, I think also I would agree that the more restrictive states tend to have less nurse practitioners because people are wanting to practice at the top of their license. So they may choose to live in states where that happens. In terms of women's health nurse practitioners, if you look back at that map that I put out, um, the states with the most women's health nurse practitioners are the states that have women's health nurse practitioner programs. Not every university or academic site that has a nurse practitioner program necessarily will have women's health nurse practitioner a women's health nurse practitioner curriculum. And I'd venture to say the same is true for psychiatric mental health nurse practitioner programs. So people tend to um, people tend to if they're furthering their education, many times people will tend to stay where they are already working.
Mhm.
So if you think about that, nurse practitioners going to graduate school, it's more convenient to go within your state or somewhere close by than it may be to travel for that. So you're going to look for the program that is going to be the most convenient for you. So we may see people who are wanting to specialize in women's health care or perhaps pediatrics or whatever, but the only program available might be a family nurse practitioner program or an adult gero nurse practitioner program, and they would choose one of those and then work in some form of women's health or whatever. So I think where our programs are is really important. And, you brought up the Midwife for Moms bill. Many of the momnibus bills talk about supporting education for maternity care providers. And so I think that looking at some of that legislation and assuring that that funding is also available for these different population foci of nurse practitioners who are working with um, maternity care, with psychiatric mental health is going to be important. And then, of course, when we look at the changing landscape of maternal health, people may opt not to go into women's health because there are questions about policy and so forth that may affect their practice.
Indeed.
Yeah,
And one more barrier. Go ahead, Teresa.
and I would also add to that, also the number of psych mental health nurse practitioners by state, but also the ability of that program to find clinical placements can be a huge
Yes.
barrier. Do students have to find their own clinical placements, or is that something that the program provides for them? What are the quality of those clinical placements? And then also the difficulty in recruiting nurse faculty, because we are, I would say it's hard to attract people with an academic salary as compared to a clinical salary.
Well, and with the credentials for academia as well.
Exactly.
Mhm.
Very helpful. I appreciate it. My my next question is, we're thinking about policy solutions here. I know we've got some other researchers and such on the line, so feel free to ask your questions as well. In terms of policy solutions, one of the things that sort of strikes me as we are talking about locations of schools that are training nurse practitioners and that women may stay there, has there been any educational institutions that are exploring ability to provide this training through virtual courses, perhaps with I think some of us have seen those like executive MBA programs where you fly in for, a week, but most of the remainder of training happens online. Are there any other kinds of creative solutions and things like that that are being considered?
Yeah, a lot of psych mental health nurse practitioner programs some are primarily online. Some offer a hybrid format where you fly in for maybe a simulation event or something like that, a certain number of weekends in either the semester or the quarter or whatever system that you're on. Um,
Great.
so yeah, and also concentrating the days that we offer classes has been helpful so that students can continue to work as while getting their advanced practice education.
Yeah, and
Great.
those solutions actually, Joy, have been around for quite a while. When I started teaching a really long time ago, the University of Missouri program, University of Missouri St. Louis and University of Missouri Kansas City, had a hybrid virtual program, which meant that I was standing in a classroom with students, but looking at 5 TVs where people were sitting in community colleges in rural areas. And that was how we were building our NP workforce. So we're talking like 25 years ago, those solutions were already being thought of. And then, of course, now fast forward, many of the programs have virtual and online options. And even though that has certainly expanded the opportunity for education to for nurse practitioners across population foci, there are policy issues involved with that. And one of the biggest issues is broadband access. Because, um, again, many of my students in rural areas would have to go somewhere. They couldn't, the people living in the urban areas with good broadband access could be sitting up at 2 in the morning doing whatever. Whereas people in our rural areas or less resourced areas, even the online programs could provide some challenges. So I think those are things we need to be cognizant of as we grow the workforce.
Great. Thank you for that question. We're actually getting some great questions in the Q&A now and in chat. Let's see, Sue, I'm going to let you take the question that was just dropped in chat, and then also ask. I actually see a question that I can help answer too. Melanie, thank you for your question. You are in school to become a nurse practitioner, and you want to focus specifically on perinatal mental health. We mentioned the courses offered through Postpartum Support International. And are there any other maternal mental health trainings that folks who are becoming nurse practitioners should be considering? I can actually take that one. And I do think that Postpartum Support International has training for prescribers that's separate from the standard maternal mental health certificate training. And we partner with Postpartum Support International in providing that standard training. So that's one thing that you can consider. They also have a list of training programs that meet the core requirements for the perinatal mental health certification, the PMHC certification, that I would encourage you to take a look at. So various programs from throughout the country. You wouldn't necessarily need a PMHC. I think, Teresa, you addressed that. You may receive adequate training through your training program and not need to sit for that board test, but it certainly doesn't hurt, I think, to have those credentials if you're in a place to do that. Hopefully that answers the question. Teresa, anything else you might add, or Sue?
Yeah, I would look into your local PSI chapter and try to find reproductive psychiatrists or reproductive psych mental health nurse practitioners that might be willing to supervise. They can be, the reproductive psychiatry community is very welcoming and inclusive of nurse practitioners. So that can also be a resource as well.
Great. We have a few more questions, but we'll turn it over to you to answer that last question, if you don't mind, from Sylvie. Sue?
I may need you to read it because I am not seeing a question from Sylvie.
I will read it. It came in from the chat.
Oh, okay. I'm in the wrong place.
Trained as a women's health nurse practitioner and recently began the PMHNP as a postmaster's. Clinical preceptor availability is a huge barrier for all specialties, she finds. Despite the need for us securing placements, delays our training and creates much stress. So I appreciate that comment too in terms of policy solutions. And I think you hit on this earlier, Teresa. Anything else that you might add here, Sue, or Teresa, around placements?
One of the things the women's health community and I would think the psychiatric mental health community are rather small communities, right? And I think sometimes we need to think a little bit about outside the box in terms of looking for those internships. One of the things I thought about as Teresa was talking was not only the PSI contact, but many states now have psychiatric mental health access programs, perinatal psychiatric mental health access programs. And because many of those have really been developing in the last, I don't know, maybe 5 to 6 years with HRSA funding. Massachusetts had one of the first. You know, I would suggest looking to some of those resources because I think you could find mentors there and certainly learn about the program. The other thing I would say, and as I was looking at the partners coming on, I was really pleased to see that there was some representation from quality collaboratives. The perinatal quality collaboratives across the country, again, because of the high maternal mortality associated with mental health issues during pregnancy and postpartum, are really looking at that issue. And that might be another place where you may be able to forge some relationships who could then help with that path to finding preceptorships.
That's a really interesting idea to work with PQCs. And we actually have the list of perinatal quality collaboratives who are prioritizing maternal mental health as one of the indicators in the 2024 maternal mental health state report cards. And those PQCs in particular, I bet would be interested in this. And we're working with NICHQ as well, Sue, on some of this. So I really like that idea. And of course, the perinatal psychiatric access line program is really interesting. And those folks are also all members of the Marseille Society of North America, who Teresa, I think you're referring to. That community is really very welcoming for maternal mental health, researchers and clinicians, and would encourage folks interested in this space to join the Marseille Society of North America. I will drop a link into chat. I
Joy,
think, yeah, go ahead. Sue.
I'm sorry, I just wanted to add also, because we are on with the policy center, there is a policy implication here. Residence training is supplemented with GME funding. Advanced practice registered nursing training is not. And so we hear this over and over again that people cannot find preceptorships. And I think that we really need to look at policy solutions that help to grow our workforce across the board, our advanced practice professionals, irregardless of type, as well as our physician colleagues, because this is a real barrier for people getting into the workforce.
Yeah, I appreciate that. I am feeling that we, and I can't seem to drop this into chat so all of you can see this, but I have a feeling that we have a issue brief brewing here from the Policy Center that includes policy recommendations that we can circulate to members of Congress as soon as possible. So thank you for that additional flag around preceptors, both Sylvie and Sue, around the policy implications here. I'm going to ask you each to just take one last minute. Are there any final reflections and thoughts that you have around advancing policy change here? And I'll start with you, Teresa.
Any final thoughts? I think we have a lot of work ahead of us. This is a great start, and I'm really thankful that we have this opportunity in this space and this protected time to think through these together, and hopefully we can move forward.
Great, thank you, Teresa. And we will be tapping you to help support this policy issue brief as well as you, Sue. Sue, over to you. Final thoughts?
Yeah, two final thoughts. Number one, when we talk about maternity care throughout that perinatal continuum, it is important that nurse practitioners be named. So many times I see, OBs, midwives, and nurses, or, physicians, midwives, nurses. If we do not say the words nurse practitioner, we are not included. So in every regulation and every piece of legislature that is affecting this population, we must be named. So I think that is certainly my takeaway. And the other second takeaway to think about is changing the language and definition around maternity care. Because when we say maternity care, that only right now looks at people who are birth providers. If we want to talk about birthing deserts, call them birthing deserts. As a women's health nurse practitioner, I am a maternity care provider. And I and people with that credential, people like me and nurse practitioners who provide maternity care, prenatal and postpartum care, need to be included in that definition. Thank you.
Thank you. Good. I also am envisioning a new image infographic of all the maternity care providers, including those who support labor and delivery, which are those three you mentioned earlier, and everyone else who can provide prenatal and postpartum care, and of course, psychiatric support. Sue, thank you for that. We are going to advance to the next slide and invite you to, continue the conversation. You're welcome to email any of us additional questions. I know there was one about telehealth that we're happy to answer offline. We appreciate your feedback. And at the very end of your Zoom session, we have a pop-up survey and invite you to take that. Next slide. We also wanted to remind you that we have some additional summer workforce webinars coming. The next webinar around workforce is the utilization of peer support specialist to support maternal mental health. That's going to be a great fireside chat with a nonprofit organization who is billing Medicaid for their peer support services and more. We'll talk about how they got started and what they're doing. We're also developing a new workforce webinar on the role of perinatal nurse navigators and perinatal social workers, and invite you to join us for that as well. Stay tuned through our e-newsletter, and you can also find out more on our events tab of our website. And then last slide just says thank you. Again, we will be providing the recording and the slides in an email that goes out in the next 48 hours. So thank you for joining us live, and thanks for those who were able to watch on the recording as well. Thank you again, Teresa and Sue, for joining us and all of your expertise leading the way in solving some of these gaps. We can't wait to continue the dialogue with you. Take care, everyone.